Good evening, everyone. Welcome to our Caring for the Caregiver series, Understanding Your Aging Loved One, sponsored by Empower and Merge, which are two of Norton Healthcare's employee resource groups. My name is Julie Lauder, and I will serve as your moderator this evening. I am a regional practice manager with Norton Geriatrics, House Calls, and our hospitalist group, all within Norton Medical Group. And I have the privilege of working with our two speakers every day. And to say that these two women are phenomenal is an understatement. So you're in for a good treat tonight. I also serve as the program coordinator for Empower. Our first speaker is Dr. Carmel J. She is the medical director of Norton House Calls, Norton Geriatrics, and our Norton Transitions and Care Continuum. She also serves as the medical director in several of our skilled nursing facility communities throughout the city. Our second speaker is Sarah Melhorn, and Sarah is a licensed clinical social worker with Norton Geriatrics and House Calls. She has over 19 years experience working with older adults.
Thank you, Julie. Good afternoon, everyone. I appreciate you so much coming out tonight and making the time and taking the time to just come. And my hope tonight is that this is an interactive learning experience for all of us. Advanced care planning can be part of our lifespan. You know, many of us here tonight probably have an advanced care plan of full code status. Many of us in the community understand full code versus DNR. When we go into a hospital, they may ask us at registration, do you have a living will? Do you have a power of attorney? Do you have a healthcare surrogate? Do you have, and you think, oh my gosh, well, I know, yeah, check all, I want everything done. And so there's not really an opportunity at that point of entry into the hospital where advanced care planning is discussed. Norton Healthcare is working aggressively on changing that. We are actively organizing an operational mode where we will have the medical order scope of treatment. It is the newest Kentucky advanced directive. The MOST form is, I would really like every one of you all to take one home and look over it and you think, well, why is she so passionate about the MOST form? I will tell you that unfortunately in the last 6 months of life for persons over the age of 80, there is about a 40% futility of care. Frequently that futility of care includes suffering. We do things to people, we do things to patients and not for people. We do everything thinking that it's going to fix when in fact that we forget or are unable to identify that sometimes a decline and a slowing down of that body is part of the natural process. I think that we are unable to, for whatever reasons, to frequently discuss that a natural conclusion to a life well lived is a dying process. And that dying process can get really mucked up if we haven't had the opportunity to have those hard conversations with our loved ones, to have I know this is really busy, but we worked on this for about 12 years. The geriatrics, Christian Furman with the University of Louisville and Justin Magnuson with the University of Louisville championed this cause. A lot of us had input, and that's why there's so many words. But it probably had 7 or 8 revisions before we were able to get it passed through our state legislative. So this is a formal document. It does not need to be notarized. It just needs to be signed by the individual and their physician. It has to be on this, it's actually supposed to be on a hot pink, it's a fuchsia. Don't ask me where that came from. But it has to be on the pink paper for it to be recognized in the state of Kentucky. And this is something that you can put in your wallet. You can have 6 copies, you can have 6 original versions of it. And the hospitals and ambulances in the state of Kentucky are required to acknowledge it. It's an ABCDE form. What we tried to do, how many times have you gone in and you said, full code status or DNR? Well, that doesn't, what about all the in between? What about someone who's had 6 rounds of antibiotics and they keep getting pneumonia because they aspirate, because they have advanced Parkinson's and they can't swallow? What about a 92-year-old who has a valve replacement and has congestive heart and their heart only functions at 10%? It doesn't matter that we have them on 30 medications, the heart is failing. right? So how many times are we going to go on a ventilator, or how many times are we going to add another pill or get another echo or another CT scan to tell us what we already know? The different blocks here specifically identifies just about every possible medical intervention. We talk about feeding tubes and ventilators. We talk about external ventilators. How many of you are familiar with the external ventilator? What I mean by that is an internal ventilator is where we put a plastic tube into the airway, and it will ventilate your lungs. And I know that probably most of you all have at least seen a ventilator, experienced a ventilator, either ourselves or a family member, and they're usually in an ICU or maybe over at Kindred. Okay, so that's the traditional ventilator. The external ventilators are now called BiPAPs, trilogy vents. We have so many patients, particularly in the South, that have obstructive sleep apnea. It can be a combination of obstructive pulmonary disease. It can be a result of fibrosis. It can be a result of just being overweight, a certain body habitus, short neck. There's a lot of reasons why we develop obstructive sleep apnea. And what the pulmonologists have discovered is that a continuous positive airway pressure, those things that we wear at night that we all, the CPAPs, they can be incredibly helpful, but they're not practical. You know, you feel like you've stuck your head outside the window and you're going down the Waterson at about 120, and then they say sleep. And then you get up and you have this, you know, right? I'm not exaggerating, am I? And we expect patients to comply. We also have BiPAPs. The BiPAPs actually help not only with oxygenation, but with ventilation, because we know that our pulmonary function, our lung function, is far beyond just getting oxygen in. We've got to get the waste off, right? And so that's what the BiPAP helps. So that's that external ventilator that this form addresses. You won't find that in most of the other, bad choice of words, in many of the other advanced directives. So we talk about hemodialysis, we talk about ventilators, external ventilators, we talk about antibiotics, and we give options. We say, you know, we might want a lot of antibiotics now, but maybe on the 8th or 9th round, when we see that we're really just getting C. diff from it and it's futile, we might not want antibiotics. If we work our way down, we talk about IV fluids and hydration. We talk about who here is decisional and who isn't. So if there's a power of attorney or an adult an adult child, that's the power of attorney. We just identified that here. I would encourage every one of you to at least start familiarizing yourself with the MOST form. You can take it to your primary care physician. If you're speaking on the behalf of your loved one, you can take it to their provider, ask that they sign it, get multiple copies, and then that can actually be implemented as the authorized official must be recognized advanced directive. Okay? Yes, ma'am.
I just had a question, and maybe it's for both of you all. Obviously, a lot of us in here either are the primary caregiver or maybe we're starting to care for an aging loved one. I know for me it's been hard because the adult that I help care for wants to maintain their independence. Could you give us, from both of your perspectives, the top 3 things that someone who's trying to support their aging loved one can do to help them, whether that's help them navigate this process or make a doctor's visit more efficient, or whatever you see that commonly, maybe you're like, man, if I had a caregiver that could help them with this, it would make a difference.
Well, I will tell you what I've done wrong over the years. You would think, I've been doing this almost 29 years now on one level or another, and I was a caregiver for a sick mom. But I still do it wrong. So I had the opportunity with my dad. You know, I was like Nurse Ratched and Dr. Kildare at his worst, chasing my 80-year-old something dad around with a glucometer, pricking his finger, right? And, you know, seeing if he's going to Heisman's Bakery to get a cheese kuka, you know. I mean, so I'm speaking as much from experience of what not to do as to what to do. I think if I would get a redo, maybe, I would say, what do you want? You know, there's something on, and I don't know the website, it's called the 5 Wishes. But they tell us, they say, ask what your family member wants. What would you want short term and what would you want long term? What's negotiable and what's non-negotiable? You know, somewhere in between those questions, we have to be able to find a reality, right? Whether that's because of limited family support, finances, reimbursement, and/or disease process. But that would be my first recommendation. And then secondly, get a plan. You know, I think at the end of the day, another area that I would like a redo on would be preserving my father's autonomy and independence, and making sure that I allow him to be the best version of himself and let go of the stuff that really isn't a battle that I should be picking, like cheesecake or butter kukas, you know.
I also think it's hard sometimes for them to have those, for patients to have those conversations with their kids because they know what they want to do, but getting it out to you, like, I don't want to do this anymore. They're afraid of how you're going to feel. They're afraid of the reaction on your face. The role has been switched. Now they need the help, and that's really hard to manage. And I think the best thing to do is not to argue. If they say something and you don't agree with it, go outside and take a deep breath, come back in, try again. You know, I think that's been one of the most helpful things I think that I've advised people to do, because then you're not upset and you're not. It's a precious time during these times where you're able to help your loved one, and you don't want to turn it into an argument and then have all these regrets, you know, after the time passes.
Yeah. Any tips or tricks for like navigating the healthcare system, or just getting the most out of the doctor's visit that you accomplish?
If they're over 65, I'd call Norton Geriatrics and House Calls 272-5087, because truly we are the best kept secret in Louisville and Jefferson County. I wish everyone had the opportunity, and I can say this because it is truly been an experience for every one of us on a personal level, but professionally. It has been such an incredible journey to watch so many families and patients. You know, we might not be able to fix it, and we might not be able to say when, but we can say how. By having those tough conversations, by making sure that advanced directives and advanced care planning, and it's never one-stop shopping, right? I mean, you go and visit something, and then you're going to come back and revisit it, and as the disease may progress or not, you know, as a unit, as a family unit, give yourself permission to change your mind based on new information, right? So I strongly would recommend that, you know, if you don't have resources within the primary care physician that you have, that you're established with, particularly if you're a Norton healthcare patient and or Norton healthcare family, because many in Louisville, I know we're just families with Norton, right? Everything is under the big blue N. And if that is your avenue for health care and wellness, then I would strongly encourage you to talk to your primary care and see if you can get those solutions in alignment. And if you can't, and the person is over 65, give us a call and we'll see if we can be of help. Certainly, we can assume primary care, because frequently transportation is a big deal in this community. The other thing I would just suggest is get some support for yourself. It is not a one-man show. And it is so hard to be the daughter and the caregiver. You know, I missed out so much with my mom because I was the nurse. I was doing her packings. I was, you know, counting how many scoops of butter pecan. I was counting the pills. Should I give Lasix today? Oh my gosh, you know, and I thought I was going to do something wrong. And it was way bigger than me. So I would encourage you to get some support. I don't know if that answered your question, but certainly you can call us, and I bet there's a lot of experience in this room. So let's hear what let's feel what other folks.
I'm going to step in one time and say one thing she forgot to say, but what I did learn is it's quality of life over quantity. So my mother is caring for my 90-year-old grandmother. They live together. My mom has moved her into the house. They live right around the corner from me, so I see my mom taking care of her, and then I'm being the support system for my mother, because it's a toll caring for someone. So one thing that Dr. Person has taught me, and then I've taught my mother, is it's about that quality of life. My grandmother loves to go gamble. She loves those slot machines like no other. But she's also got COPD. So we know when we go gambling, there's a lot of smoke, right? So it's about weighing that every time she would go over to the boat over in Indiana, she would get sick.
I just holler in a steroid pack.
And so, so my mother would get so frustrated and so mad that that her sisters would take her over there because there it is, my mom's stuck now taking care of her. But what we had to, get my mother to realize, and, it is the help of all of us that what my grandmother has chosen is the quality of life. She knows that going over there and getting that and inhaling all that smoke, that it could take years, it could take days off of her life, but while she's here, she would rather have that quality. So I think of being a caregiver and seeing my mother be a caregiver of someone, that is the best thing. My grandma's happy. She knows the consequences of doing it, but it makes her so happy she doesn't care. And knowing that she's happy, the rest of us are happy. So now, if we want to collect the cards, and we can go and we can start answering some questions. Obviously, if you don't have anything written down and you just want to raise your hand, we can do it that way as well.
I was just wanting some tips on how to approach your loved one about changing to a gerontologist. I am a family of 7, and there's like 4 of us that are nurses. And whenever we take her to her family doctor or to her practitioner, my mother's told, my mother's 91, that she's old. But how does she get how do we approach her about changing to a gerontologist?
She goes to Baptist.
Who is, well, whose doctor is the BHE family.
Sure.
And
we like them. We can say that, but we like them.
How do we do that?
So, and I learned this too when and again, I'm going to refer to Dr. Henry. So when I joined Norton Geriatrics, I was coming in to help partner with Kitty and take over some of her patients, right? Oh my word. You talk about shoes to fill. And the relationship that Kitty has with her patients and their families and their neighbors and the neighbors' families. And she can tell me more about the neighbor's cousin's brother than I can tell you about what my dad was doing yesterday, right? And what I encourage is, so we have to respect that relationship. That is a physician-patient relationship from a generation that we don't really know, right? Because we don't have that same value system, or it's not nearly as respected the way their generation did. So what you could say is there is a group of geriatrics, and we're geriatricians. So gerontology is just a sort of gerontology is the study of aging. Geriatrics is the study of aging and disease process, okay? So a lot of times I just tell folks, when we were kids, Mom, you took us to a pediatrician, you didn't take us to an adult doctor. Now there are specialists that all they do is provide care and clinical support as well as wellness and psychosocial support and resources to people over the age of 65. That's what they do. And try to emphasize. You can't make them, but that if because they're always going to be the mother, right? So if you say, it might, mine was too, but it might resonate. Okay. Question over here?
Question about the most form.
Yes, ma'am.
Does that replace like the advanced directive or living will or power of attorney? Is that the goal eventually of that form, or is that going to be replacing?
Well, we have to be realistic as geriatricians. We know that it takes decades to move a mountain. I mean, this was about 10 or 12 years. I'm sure Christian could tell me, or Kitty, but it's been a long time. Our hope that this is what would be the official authorized version to tell another physician what to do or what not to do. You hope that after filling this out, that if you have a power of attorney or a living will or an advance directive, that you go back and revisit those and you get the language reconciled that would be parallel with this language. Make sense? So that the goals are specifically the same. In other words, on one advance directive, you don't want to be a full code, and then on here you say no feeding tube, do not resuscitate, no hospitalization.
But can that be used in place?
Yeah,
absolutely.
Yeah, I've been using
so someone
them
can
across
just fill that out.
the board.
That's
It's so
Absolutely.
much easier and more extensive on exactly what you want to do. So maybe pass it around so we
Sure.
can have
Kim.
I have a follow-up question to that. So my dad is getting older, and it's about time to start having these advanced care planning discussions. Do you have any tips or tricks on how to initiate that conversation, especially with someone who's stubbornly young?
Because it's never going to happen, and the best time to have the conversation is when you don't have to have the conversation. It is amazing. I go to a lot of dinner parties, I guess with older people. Don't tell my friends that. And it is funny because I'm like the most popular girl there because everybody wants to talk about how they want to die. Because none of them are dying and they've had too many martinis, right? But it's really, it's true. I mean, it's true, and so I think because we all want to have say and power over how we do that part of our lifespan. And that indeed, while it might be a dying process, we don't know what the dying process is going to look like. The dying process is part of the living process. So I would say go online and read the 5 wishes. 5 wishes is what I'm saying. It's informative. It speaks not only to the clinical world and the legal world, but it also speaks to the heart and soul of being a human being. You can get online if you put most I shouldn't do anything. Most Kentucky form, that will pull up. But I'm going to go out to my car and get the fuchsia copies and just hand them out. Read over it and reread it and read again. Start talking to your dad about, Dad was at this event the other night and they were talking about advanced care planning. Advanced care planning.
And I think the biggest mistake all of us make isn't, like she said, not having those conversations beforehand, because while you're in crisis, you don't know what crisis feels like. It's an individual thing. And what my crisis is may not be yours, but once you're in it, it's like you're drowning. You don't know where to go, you don't know what to say, you're tired, you can't sleep, you can't eat, you don't know, you're just, and you can't make decisions at that time.
And all those white coats are coming at you.
What do you want to do? What do you want to do? I don't know, who am I? So, very good. Kidding.
Carmel and Sarah, my friend Jane Keebo, who I know Carmel knows, who's a semi-retired gerontologist from U of L, she had what I thought was a great idea when I was trying to talk to her about issues with my own father, who he's now 93, and he did actually have a living will and stuff. But she said to take some of the focus off the older parent who's maybe declining, that you can sort of make it a family issue, and all of your, assuming you've got them, all of the siblings, like middle-aged and older siblings, can get together, and you can throw mom and dad into the mix, but you can all get together and all kind of say what you want. That way it takes some of the focus off of the parent, but still maybe gets the job done, and maybe gets the job done for you. Like I'm 65, everybody my age ought to have that already done. So Jane said sort of make it a family affair.
I had a friend of mine once tell me, I had a friend of mine once tell me too, come at it from the perspective of like, tell me what you want so I can make sure it happens for you, so it becomes more like, what can I do for you? I didn't know if that was successful or if that was
I think, just with my own parents, we've already had those discussions. We've got everything in place just because I brought it up. It wasn't, it wasn't on the top list of things to do. My mom was just having fun, being retired. My dad's still working. He likes to work. That's what he does, That's not something that they were thinking about. But I was like, we need to talk about this so that I don't want to be the one in crisis. Like, I don't want that with my own family. I can do it for everybody else, not me.
And along that, so Sarah has the insight because we see what happened when we don't. When you are in that ICU hallway and you've got 3 white coats coming in, what do you mean you don't want to give them a chance? And I have seen ventilators and tubes go in places that should never happen. But set an anniversary date. Every year, have the conversation. Have it when you're driving to the horse track. Have it when you're going for ice cream. Have it when you're having, you're doing the deviled eggs for Thanksgiving dinner, because it's a relaxed, non-threatening environment where it really will at least place the seed. And when you're healthy, it's never going to happen, right? I mean, I'm coming up on a big birthday, and it seems like yesterday I thought 40 was old, and now it's like, oh my God, those whippersnappers. But, so it's never going to come. And so if it's never going to come, then I can easily tell Sarah, I want this or I don't want that. But if you make sure that you do it annually, as either health improves and rehab progresses, or perhaps as disease progresses along and functional status digresses, then at least you have this marker. You know, every year we're going to talk about this, and you have some sense of what they would want or what they wouldn't want. And here's the thing, you all, it might change. You know, this is just a plan. It's a blueprint, knowing that depending on individual circumstances, things might change.
Do you have a question?
Yeah, the pink sheet that you were talking, the one with the directives, is that something that you bring with you at the hospital when
Yes.
you're admission, or does that ever get scanned into your
No,
medical
it does, but
records?
you don't want to take for granted the fact that they're going to look for it. You want to have your copy so that, right away, you know exactly
So
what.
every time you would have to go to the hospital, you want to have those directives.
And it has to be on the pink paper. It has to be on this fuchsia. You see the color of Camille's sweater? Yeah. That is the color of this that is recognized in the state of Kentucky. I do not know how we got with that. That was the only color we had when we printed it. And that was the one that actually was passed through legislation. But I'm going to, like I said, I'm going to go to my car and make sure that on leaving that you all have that, okay?
Yeah, so Sarah is just
Thank you,
handing
Sarah.
out copies just so everybody can see. Again, you couldn't use this document because it's not on the pink paper, but so everybody can see.
My chart.
So the Norton Healthcare, I'm actively working with Brian Reddick. We brought it to the board Wednesday before last. Our goal is to have the most form inpatient and outpatient in the electronic medical record. Okay. The problem is that while the information would be scanned into Epic, it will not be on pink paper. So
We're working on that.
officially, yeah, we're trying to figure out how we can make that happen. But Norton Healthcare's goal is to, number one, they recognize the value of the most forms. They also recognize the value of having a standardized, authorized scope of orders that every physician can recognize and honor. And they want to standardize that across their entire electronic medical record so that every provider, regardless of the level of care that the patient is going to have access and know how to utilize the most form.
And it also comes in handy with the ambulance rides in case, something like that happens. It's a doctor's order, so it doesn't need to be notarized like a DNR.
There's a different version. The ambulance had to.
Yes, I think it's
They
called
don't,
post.
because now you've got a doctor's order and you can
POLST.
say, this is what they wanted done.
Post PO. The question was, is there a version of the most form for Indiana? There is, if I'm not mistaken, I believe it's the post. Kitty, is that the post form? You can go online and get that. I'm not overly familiar with the very specifics of it, but I'm sure the website there would help you better understand what has to be done for it to be honored. More questions?
So I got a couple. Oh, you want to go on?
I'm the oldest child. My mother's 89, and I'm the only one that doesn't work right now, so everything's falling to me, which is fine. I have the time, but I have 3 siblings that are not coming along with me. They don't see her every day, so they don't believe, I'm like, you do know she should not be doing this. She can't do that anymore. Well, maybe she says she can. I'm like, well, she can't. I don't understand. I don't know the best way to get them to come to my side. Come over to the dark side.
a lot of times what I'll say is that, if you're the center, if you're the hub, then you need to start delegating so that they understand exactly what it looks like to have to be in a support role. Because if you've never done it before, you don't know what it's like. And, don't be afraid to say, hey, can you come over on Tuesdays and do the laundry? Or, hey, Thursdays, can you do the shopping? As a caregiver, you want to own it all. And, I'm in charge. I got to make sure all this stuff is done. But it's never not okay to ask for help when you need it.
Well, and she's not quite to that. I mean, she still does her own laundry.
Sure.
She doesn't. I take her to the grocery, but she's got to pick everything out because it's got to be certain kind. And and I get my siblings. Sometimes, but sometimes I think she's just on more with them than she is with me. She'll say, "Oh, I got to sit down because I'm too tired." I don't know that she says that. They just see her one way.
Do they live here in town?
Uh-huh.
There is usually what I call the golden child effect, and that's not disrespect to any golden children in here, but they either live away and come in on Mother's Day with a big thing of flowers, and why is my mother on 18 pills? And I'm on camera, so I'll be. But they really don't have a clue as to the day in, day out functional status of their parent, and So it's important, to Sarah's point, I think Sarah brought up an incredibly valuable share. Come and stay the day with mom. Come and take dad to the doctors. I frequently want, we had an opportunity this afternoon, a couple hours ago. There is a son that wants his father to have additional imaging. And everyone, including social workers, nurse practitioners, physicians, physical therapists, understand that because of a sentinel event, a fall with a head laceration or a subdural or head laceration, his dementia is now exacerbated. And his functional status is about 35%, 40% of what it was. And the one adult sibling will not recognize it. But yet he's in Montana. And so I said, get him home. If he wants to make these decisions based and try to advocate for his father, he needs to be here. Let him stay 2 nights in the facility with his dad and see what that looks like. Because I don't think anyone knows how much we lose ourselves and become a patient when we get sick. Something as simple as putting on a hospital gown or having that white bracelet put to us, much less being transported down a hallway on a gurney, right? Or out in the hallway and you're taken in for x-rays and you're a liver and, somebody comes and flips the lights on at 3 a.m. and pokes you here and pokes you here and, the reality of it is being sick is really hard and it's borderline at times dehumanizing. And I think that if everyone had an experience to see the reality of what being older and being frail and being sick, I'm not talking that, I don't want to miscommunicate. There are hundreds of thousands of seniors who age healthy and well and thrive and function independently and autonomously, and we support that. But for the folks who have failing bodies, whose minds no longer serve them, who are completely dependent on every aspect of daily living, and who remain full codes, the people that make the decisions on their behalf, I just want to make sure that they're informed of reality. That's all I'm saying.
But just one other, even the healthy ones, like so many times I'll have my tick patients and I'll see them and they're like, this hip is a whole lot different than the last hip I had. Well, that was 5 years ago, and now we're 75 and we're not 70. So they can't understand why it's so much more difficult now than it was 5 years ago. So even if they're healthiest, they're still 5 years older. So none of us realize as we age, So
it's almost like when we're pediatrics. Look at the difference of what happens between when we're 7 years of age and when we're 12 years of age. And that same age progression can be exponentially increased when you age. 85 can look a whole lot different than 90. And the functional status, that overall functional status, is something that we use as one of our markers to help prognosticate disease progression and a dying process, lifespan. More questions? Julie had some.
I've got a few that I picked up here. So my 91-year-old wants to drive. What to do?
Can the 91-year-old drive?
Sure. We don't feel like responsibly. It's our mother.
Okay, so here's what I try not to do. I try not to take an age number and sort of pigeonhole a limitation or restriction on it, because 91 I have, so a couple things. To have an objective assessment.
Yeah, we thought about that.
I want to call it the Fraser.
Yes, it's at Fraser.
Over off Newburgh Road. If they've had, what I tell my patients, and the men are sorry guys, but men are harder than women. But Louisville's a driving community. I did training in Boston and it was never an issue. But here can be a real challenge. So a lot of times I'll say, look, I'm not going to put on your doctor's note that you can drive. If you choose to drive and you have a wreck, insurance has the right to not cover that. That'll get most of the men's attention because they're under driving restrictions. The same like if you have a seizure disorder under a certain time frame, you cannot drive. But then I say, I'll write a prescription and recommend them to go over and be tested, and if they pass, that's not my area of expertise. I shouldn't determine whether someone is safe to drive or not. I can have an opinion, But if they pass, then they pass. If they don't pass, sometimes you just have to take the keys. It is, you won't get a redo on those. How many times have you picked up the newspaper or turned on the television and someone with neuropathy or impaired reflex or impaired sensories hit the gas pedal and thought they were hitting the brake? So it would be a horrific thing to live with.
So another one, and Sarah, I think this is definitely towards you. Applying for Medicaid, is there a simplified list?
I do have a list, and I can write it out for whoever asked that question. Okay, I can help you. That's a whole other system in itself, and it's really hard. How
about we do this? If everybody has a pen, I'll give you Sarah's email.
Yeah.
And you can email Sarah, and she can forward that list to you.
Yeah, I can do that for you.
I think that would be great.
And if there's assets and stuff like that, I have other people in the community that I can, help everybody with and get in touch with and know where, the point of entry, which is a lot of what I do.
Do you want to kind of just give a simplified version of how you qualify for Medicaid? Like assets have to be $2,000 or less?
Yeah, so they're total assets unless you do a trust, which is where people who have, houses and money and stocks and bonds and investments. Before the 5-year look-back period, if we can get all that into a trust, no longer exists. So they have to be down to $2,000 worth of assets. That trust protects them from any kind of retroactive from the state, everything. It's like that money doesn't exist. If you don't have any money, basically it's, you have 2,000 or less, you can't own a home, those kinds of things. And you need bank statements and I'm trying to think what else. Cash value of life insurance policies, just any kind of asset that they might have, you're going to have to cash it out, use it for their care if you haven't formed a trust with a legal attorney, an elder law attorney. I'm trying to, and then going to apply, the Medicaid beds in the community, they still are not to where we need them to be. Kentucky's an as-need state, so there's certificates of need that they don't give out anymore. Your best bet is to, go from a 3-day stay into a nursing, rehab place, and then maybe have social workers or somebody there help you find long-term care. And that's your best bet. Coming from the community, trying to get a Medicaid bed is almost impossible. So if you ever find yourself and you're questioning, hey, do they really need long-term care? Is this what I'm thinking? And because it would be a worse situation if you get them home, then realize you need long-term care because it's just not there. Use the resources while you have them. And if you ever are in a situation like that, everybody's got my email, so you can bounce ideas and questions off me anytime. I'm never, too busy to help. But Medicaid is really hard, and there's not a lot of available funds for it. Out in the community, you have to be pretty much destitute. Nursing home's different. You spend down $2,000 and then you're in the bed. But any other questions about that I didn't?
Suzanne, do you have anything to add? No. Okay.
Okay.
Another question is, if parents are Norton patients, can they still take advantage of transitions of care? Is it Medicare allow switching? So for the transitions of care, currently it is if you're in a Norton hospital and you transfer to one of the 6 different skilled nursing facilities that where our TIC program is located. You don't have to be a Norton Healthcare primary care patient. So it's if you were in a Norton Healthcare facility, so either St. Matthew's Women's and Children's, that's right there, Norton Brownsboro, or Norton Audubon, and you go to one of the 6, if you're in that hospital, and then you go to one of the 6 skilled nursing facilities where we partner and have this program, yes, you can be in that transitions of care. I will say that we've had some patients that are at a facility and they didn't come from a Norton hospital, but they know about our TIC program and they ask questions. Ask questions. You can maybe get in.
Right. I was going to. So we would love to increase our transitions program. We really believe it's the next best thing to sliced bread. So if you are in a Norton Healthcare hospital, and it doesn't, even if you're in the one downtown, remember the word TIC. and again, I'm going to make sure that you all have a brochure, but it's transitions and continuum of care. It makes sense, doesn't it? You're transitioning the level of care from a hospital to a post-acute or a rehab, and then back home. And so that consult, just talk to your caseworker or the social worker or the physician. Be pushy if you want. You know, Norton Geriatrics, look us up. We have a website. You could always go to our website, call, consult can go out, and we will do our very best to accommodate that. The two qualifiers really is that they are a hospitalized patient and that they are going to a rehab.
Yeah, and just, you know, as an example, we just had a lady who was downtown, was not part of the TIC, but was in one of our buildings, desperately needed help. She was not, producing any kind of, what would be, I guess, with therapy, just not progressing at all. And so we came in, realized we needed long-term care, didn't have a power of attorney. I got, bam, done. She's placed, she's safe. She's not going to fall at home and go back to the hospital. So that's just like an example of how we can, come in, and even when, we didn't identify you at the hospital, we can still help you if you're in the rehab.
And then the second part of that was, it says, does Medicaid allow switching? Can somebody elaborate on that?
If your parents are on Medicare, and they're not Norton patients, can they still go to a Norton facility today and a Baptist house tomorrow? And
Absolutely.
It doesn't matter because Medicare keeps.
Yeah, correct. You're correct. Right. Yes.
Ideally,
yes.
Continuum of care. So ideally, we want a well-coordinated, closed circle of providers. We don't want anybody. We don't want just anybody to touch our patients, right? And we're a little bit protective. We have a turf. No, I mean, we work within the community, but the truth of the matter is if you are under the umbrella of Norton Healthcare, then those providers are going to know about our transitions and continuum of care. I bet I've got half of Louisville's physicians, subspecialists. If I don't have the number, Kitty has the number, Sarah, cell phones. And, we get a hold of who we need to get a hold of when we need to reach them. And there is such an added value in that, I can't even begin to explain. So, of course, we want to be inclusive, but the ideal situation would be that all the care is under Norton Healthcare, simply because it's going to improve the continuum and decrease the risk of fragmented, disrupted, miscommunication